Hello and welcome to the International Forum on Quality and Safety in Healthcare here in Amsterdam. We are here from the Norwegian Knowledge Center for the Health Services, and I'm Karin Lindahl, Director of the Department of Evidence-Based Healthcare and Quality Improvement. With me today, chairing the session, is my co-worker and experienced healthcare leader and improver of quality, Vege.
Hello. We are delighted to welcome to this specially designed session about quality improvement and large-scale system change. I am so happy to say that joining us to discuss this topic are Sir John Oldham, to my left, who is the National Clinical Lead for Quality and Productivity at the Department of Health in England, and Dr. Jim Easton, who is the NHS National Director for Improvement and Efficiency in the UK, and Dr. Lynne Maher, who is the Interim Director for Innovation at the National Health Services Institute for Innovation and Improvement in England. Thank you so much for joining us.
Great to be here.
We actually have the best for giving us insight and inspiration on this topic. But before we start, Karin, can you give us a background picture from Norway?
Well, the current status or backdrop for this discussion is the local situation in Norway and what we can learn from you, international experts on this field, in relation to our own challenges. At the moment, we have new healthcare laws and a reform bill focusing on coordination of care and putting more emphasis on strengthening the primary healthcare field. The question remains on how best to do that. And so this is what we would like to address in this discussion. In Norway, we have been fortunate enough not to be so much affected by the financial crisis. However, we do have the second most expensive healthcare system in the world, and it's not sustainable in looking into the future with an aging population and, of course, reduced income in the years to come. So we also have another challenge in that we don't know a whole lot about the quality of the services we deliver, and it's more and more evident demand from the public to know more about the quality and what to expect from the health services. In addition to this, the question about equity is also high in the public on the public agenda, and of course in this country of ours, which is long and vast and with relatively few inhabitants in 430 municipalities, that is a challenge.
So there is a need for initiative and maybe initiatives to point out the possible solution to these pressing challenges. And we have therefore chosen in this panel to focus on Great Britain as an example, especially England, on quality improvement and large-scale system change that you are working on as we speak. So we think that we should separate this panel in three different subjects. First, the great national challenge, how to set the national aims. And secondly, how to break down and organize the huge transformation of the healthcare system which are in front of us, and how to solve the challenge of national implementation. And finally, we would like to see how this affects and how it challenges the local microsystem. So first, what do you see as the greatest challenge for the health services in England right now, and what are your aims for the next years to come?
Well, I think actually you've outlined it already, which is the same for your healthcare system, ours and many other people's, which is the tsunami of need that's coming from the growth of people with long-term conditions, and not just one, but multiple. So that is why just thinking down disease-specific strategies is not a way forward. But it's framing that challenge, as with any large-scale change, you know that the beginning of that is framing that challenge in a way that resonates with people's day-to-day existence and the culture that exists in a way that grabs them, and they feel we have to do something about that, at the same time as articulating that desire in some harder goals and visions, which Jim will probably talk about, so that there is a clear framework by which you're trying to move people forward. But the starting point is framing the challenge in a way that gets the buy-in from people as to what is facing the healthcare system, because frankly, as you said, none of our healthcare systems are sustainable if we continue to manage people with long-term conditions in the way we do now.
Of course, I completely agree with John. It's very interesting. People talk about how our systems can't be sustained. I'm not sure whether they're prepared to believe it yet. In a way, I've been privileged to visit Norway and try and afford to buy a glass of wine in a Norwegian bar, which it sort of illustrates the sort of slightly different place our two countries are in. Because our economy has got into a very bad place, it brings us face to face in a very real way today with the issue. Before that, people knew something was coming that was difficult at some time in the future, but we could always put it off for 1 year or 5 years or 10 years. And my guess is that one of the challenges for your relatively rich country is whether the time is now to do some of the difficult things you have to do. But even in Norway, we face the prospect of being the generation of healthcare leaders that failed to hand over a universal healthcare system to our children and grandchildren. And that's a terrible prospect. And I think we're a little like the energy industry was in the 1970s. People know that it can't go on, but it's hard to change. And so for us, it's been forced on us. It's difficult, but I think it's welcome. I think one of the real challenges for you is to find, locate people in the reality of, if we care as deeply as we do about universal healthcare as a pillar of our society, a value we share, then the time is not in 2040 or 2050 or 2080. The time is now. And I think it's critical, and I'm just hugely impressed by the kind of appetite to grasp that challenge.
I'd like to just build on something that John said about framing. I completely agree. And from some of our experience, what we found is that staff working at local level can't really understand what the national targets mean at local level. You know, what can I do as a staff nurse in a ward? What's my responsibility? How can I add value? So I think that's critically important, help people to understand how every member of the workforce can add value to that, and to help bring the voice of the patient forward. So those patients who are demanding different healthcare services, how can we make them really heard?
So what would you say are the 2-3 most important issues to work on to really change in the system?
I think for us it's clear. We start by saying we're on a journey for better quality. We've been very clear about what quality means, and I think you have to take it away from a word that means so many different things, and we've defined it very clearly in terms of the outcomes, that the clinical outcomes, the patient experience, and we've turned that into measurable things that we want to improve. We want to improve cancer outcomes. We want to improve the life chances of people with long-term conditions. So it's very clear about quality. And for us, and I think for you, the only way to do that is to change the relationship between quality and cost, and to do those two things together. When you make that analysis and you start to think, what does it mean, you immediately come to the issues of long-term condition care. That's where this will break. It's where we have the biggest opportunities to change the pattern of service in a way that drives both quality and long-term and affordability. You come to the whole pattern of emergency care. You come to exclusion, disadvantage for people. You come to children and the chance to intervene early in young children's lives. This idea of the 5-year gestation, it's in the first 5 years that we set people on a path for life. So I think if you start with a frame of being clear what quality means, and what as a nation or a local community you're aiming for, that you're doing that within an environment that's affordable, it takes you immediately to the issues that you've got to tackle.
And I concur, it is, predominantly around those issues. And everybody, you'll find, my guess is, as we find, you go around the country and say, oh yeah, we think that's important. And it goes back to this have they really, have they really accepted that there is this cliff? You know, there is this, I talk about a tsunami of need, which is, you know, it's this wave hitting you. And I don't think it's been internalized sufficiently. And part of this is to create the urgency and the imperative. So one of the tasks is to create the urgency imperative about these issues. But everybody thinks they're doing it. As I go around the country, everybody says, oh yeah, we're already doing that. And then you say, yeah, well, what about your emergency admission? Oh, well, those are going up. What about your rehab? Oh, well, those are going up. And you find what happens in our country, and I think a little bit in Norway, but I'm happy to be told off if that's not the case. We have what I call chronic pilotitis. People do bits of pilots here and there, and then they think they're doing it. And this now has to be core business. It has to bring the thing together, drive the change through, and maybe the starting point in the conversation is what some of our colleagues have done, which is to demonstrate the variance. Everybody thinks they're doing the best until you demonstrate to them there are differences in the system. And to be transparent and open starts the conversation about maybe we're not as good as we think we were.
I agree with that. And I think, you know, the sooner people know where they are in the system in terms of their performance and their ability to meet patients' expectations, then that can start some of the ambition, because they can say, what does it take for us to move up to much better performance?
The challenges on the national level is one thing, and then bring it out to the nation and to implement all the best pilots. So it's a national contribution and not only a pilot. What's your idea of bringing this challenge out?
Well, this is fantastic, because I mean this is difficult, and he and I work together, and we wrestle with this all the time, and Lynne and I have done. I mean, I'll start with a couple of things. People in England get into a debate about should we be doing this top down, or you know, because we'll get focus and concentration of effort and clarity about best practice. Or should we be driving it bottom up, where we get engagement, buy-in? And my answer is yes. You know, it's yes, but it's not enough just to say yes, because the maturity, the culture to do that is very weak for us. So in England, we've encouraged people to have these two polarised, immature models of change. Number one is someone at the centre will tell me what to do, and they will beat me to death if I don't do it. That's how we did improving waiting time in our accident departments. We were, from the top, absolutely ruthless. We got the result.
And people did get beaten to death.
And they did. They lost their jobs. They lost their jobs. And we got the result, but we made clinicians very unhappy. At the other end, should we in every local town allow people to work at their own pace, develop pilots, find their own through? You get engagement, you get buy-in, but you get a huge amount of variation and very slow pace. So the task is, how do you join those together? And what we're trying to do, and we find it difficult day to day, is to say we're going to set some things nationally that we have to do. We're going to be clear what the objectives are. We're going to require everybody locally to have a plan for how they respond. And we're going to try and provide support across the country to join people up, to shortcut the processes. But it's difficult. People still find in our country the process of joining up a problem. Their mindset is, I don't want to work with those people from London because they think they're really clever and they don't know what it's like up in the rural part of the north of England. And so we work at it all the time. And what John and I are constantly wrestling with is my desire to push people hard versus the need to keep people engaged at the front line. And you can't solve it, but you have to wrestle with it.
Yeah, I think that's true. And just to reframe it in a slightly different way, that what nationally you can do is raise people's anxiety about doing nothing. And part of the message and the framing is that, but you can also do things in terms of policy and in terms of other things, incentives and disincentives, that raise people's anxiety. Well, if I do nothing, actually, it's going to affect me. At the same time, that the more local development stuff can demonstrate to people that the change you wish them to do is achievable, and that reduces their anxiety about change. And you've heard me before talk about creating this gradient. And what I think we can do nationally is that. And the wrestling bit is the discipline and rigour by which you track, measure progress and hold people accountable to that, when you may not have any direct managerial control over them, and that you have to win their hearts and minds, and their hearts and minds have to be bought into the discipline about doing it.
I think, of course, it's incredibly difficult, and I don't think there is one single way. I think, you know, every 2 months, every 6 months, depending on who you deal with, you have to balance a little bit between, you know, national need and push and local ownership. I think one thing that we were talking about earlier is this understanding of where people are in the system. And certainly in England, we have organisations who are doing lots and lots of improvement work. But when you really go in and see what they're doing and say, okay, you've put a lot of time, effort, resources into this, but how are all these 10 projects going to maximise your potential strategically to meet the national needs? And the national needs are about giving great quality care and fantastic patient experience. And I think there is something about really helping those leaders, clinical leaders, managerial leaders, to understand what's going on in their organisation and saying, how do we take all this resource, we've got an abundance of people doing things, but get them to align it so that we really achieve the 3 or 4 major things that are going to make the biggest difference.
And it is that, it is that focus. It is being completely clear with people that there are hundreds of things, and some might be interesting, some might not be, but actually, as national leaders, you've got to be really clear that for the next 2 years, these are the 3 things we're focusing on. Everybody, you know, if you're doing other stuff, that actually isn't stuff we want you to be doing right now. We want you to be focusing on these 3 or 4 things.
That's exactly right. So the question, so my boss, Sir David Nicholson, the Chief Executive of the National Health Service, the question he asks me, which I think is a powerful question, is what is it that only the centre can do? What is it that we can only do nationally? And they are things like be clear about what's important, change the way the money flows through the system to reward the right practice. For us, set pay levels and conditions for staff. Only do those things. Secondly, for the other things, what is our job to support them happening at scale locally? How do we support local communities join up, but not to get confused about trying to do nationally those things which need to be done somewhere else? Because it's tempting, wherever you are, particularly if you're me, you just want to,
He's tempted all the time.
you just want, which is why I hire people to can train me. But it's a very good question. What is it, wherever I'm working, what is it that only I can do at the level I'm working to make this work, and how do I support the other things that need to happen?
And since we're talking about the meeting of the national and local level and the wrestling going on there, I love your story, Jim, about the SPY.
Yeah.
How do you think you can support the need for learning from each other and strengthen the need of learning from each other, from the best examples?
I keep getting in trouble in England. I was reported in the national kind of health newspaper for talking about the learning culture being disgraceful, because I think it is. People who say that they care more than anything about healthcare are still very reluctant to learn and apply lessons which would make care better for their patients as quickly as we would like. So we have a cultural problem. I think there are a number of ways of helping to get over it. One is to have systems which, you know, people like Lynne are responsible for, which do make available and in a very positive way spread great practice. Secondly, to do the things that Sir John does, which is to run fantastic programs which join people together and get them to feel excited about learning, to do it positively, to see the energy that comes from a sharing. But you also encourage some healthy competition, I know, in your work. I think there are things people should do as individual leaders by modelling this change themselves. It's actually very easy when you're faced with a problem as a leader, instead of saying we need to run some kind of exercise ourselves, it's very easy to say, let's just go and learn from the best. It's particularly powerful if you learn from your neighbours. Yeah. You know, instead of learning from Kaiser or Tayside or John or Lynne's work, to say, well, let's go to our nearest neighbours and learn what they're doing, because that's when you're serious about learning as a value. And also to set objectives for your staff, to say, you can't be successful in this organisation unless you show how you're learning and teaching. You know, unless you show that in the work you're doing, you're finding the best and making it work. So I think there are some very practical, easy things that generate positive energy, but you have to push through quite a strong cultural barrier. And when we've talked before, it seems to be real in Norway as it is in our country too.
And I think some of the sustainability comes from actually creating that energy at the front line, but also about investing in your leadership skills and expectations to make sure you're embedding this culture of interchange and learning, which we haven't had, as Jim quite rightly says, and people, you know, get hot under the collar. But it's true. The number of times I go to places and I'm actually connecting people in the room who I know have done the things that they'll mutually find useful, which I'm in the privilege of knowing because I've been around them. But you know, if they'd have driven 50 miles up the road, they'd have found out. But if the leadership culture is about learning and improvement, and invest in that as well as in the financial mechanics and stuff, we start to get a culture that's more sustainable.
I think you can do that at two levels as well, Anders, in terms of you're describing the national level. I think this is a very good example for you, a bit role modelling nationally, that you're talking to people in other countries to try and understand how they've approached the challenges, but also, as we've been saying, at local level, helping connect people and share good practice and looking at multidisciplinary sharing, but also thinking about same groups, peer groups. So we did quite a lot of work with nurses saying, give us examples of things that you're doing fabulously well every day that if spread across the country, if shared, could make a big difference. And that resulted in 8 high impact changes that nurses have valued and are copying across the country.
Makes it quite natural to look into the local system and see the change happening there. Do you think that you can get everyone on board? I remember your large book about small book about
it just felt large to read.
Oh, thank you.
No, it was an important book for me, so it's been modeling a lot of what we do in Norway. But you think of in waves when you see how this could be national-wide?
There are different ways you can cut this, and I've done it both ways. What we're actually seeking to do now is actually engage as much of the country at one given moment as we can, because that's the imperative that's driving rethinking how we do that. So the book you refer to, I wrote sort of, 6-7 years ago. And so there may be yet another small book about large system change, bracket slightly larger than the last one, bracket, which is how do you create the mechanisms where you have a go across the whole country. And if you want to get down to that level of granularity, it's about making sure in each of the different geographies there are examples of what you want to achieve. It doesn't matter how small, but there are examples and people who can talk how they can implement the system. The second bit is to go for the population geographic coverage. using those as nodes. A similar sort of way, but a much shorter time scale, much bigger impression. Will you get everybody? No. But I actually work back from the numbers that I seek to get 30% involvement. If I know 30% delivery, sorry. If I know I've got 20 to 30% delivery, 20% is classically the tipping point that you know the rest is going to go. And in stuff I've done previously, I felt it. You can actually feel it running away from you. So I aim at 30 to give me some headroom. And you work out the mathematics from your population. What's that? What are the numbers of doctors? And you actually plan it through if we're going to get down to that level of granularity.
It's all about math, isn't it?
It's all about math.
When we are at the local level, we are at the level of the population and the patients. So, Lynne, I would like you to explain something about how you experienced getting the patient involved in a new way.
We've always, talked in health systems about involving patients, and I think everybody has tried to involve patients really well with forums and, even our satisfaction surveys to try and understand. But we started to look about working with patients in a different way and more of a partnership than where the professional managers or clinicians and you're the patient. And so we learnt from another industry, the service design industry, and took some of their tools and methods to engage patients to tell their story of their experience, so that gave us new insights about what was happening, things that we hadn't seen before as managers or clinicians. But then not just say, thank you very much, patients, we will go and now redesign the service, but continue that work with the patients and their family members and staff together in a partnership to redesign the service. And there's a lot of fear at the beginning saying, oh no, the patients are going to want something that we can't deliver or we can't afford. We have never found that. Patients and family members are really good at identifying where there's waste in the system, where there's safety problems from their perspective, where there's unnecessary steps in the pathway that us as professionals have put in there because we think the patients and family members will want them. And they're saying, why is this here? We're not getting any value. So time and time again, we've been able to increase quality, increase safety, increase the patient's experience, make that better, and for a lot of the work, reduce costs, either by making the processes safer or taking out elements of the process that were really not adding any value. And it's been phenomenally well received both by patients and by staff. And it's a method of engagement at local level. What we found is instead of trying to say to staff, we really want you to do this, here's an improvement programme, and staff saying we're too busy, by playing typically film of what the patients are feeling as they go through the journey, where there's negative feelings, staff say, they put their hands up and say, how can we help? It makes a different dynamic.
It's worth just adding that everything we're doing right now with improvement teams throughout the country, patients are actively round the table as members of the improvement team. Yeah. One of my maxims is they are the most underused resource in our healthcare systems.
Yeah. They are the experts.
Right. So in a way we have two challenges. It's to find out all the best experiences in the country and try to build on that into the future system. But at the same time, there is a second challenge, and that's what we haven't learned yet, the innovation part, how to build a system totally different. Can you give some glimpse into the future?
I'm going to start and then talk to someone who actually knows something. Our analysis about the quality and cost issue suggests that we could get through the next 10 to 15 years by redesigning the current system. But probably not longer than that. And so beyond that, you have to start thinking much more deeply about some of the building blocks of healthcare. You see, we're busy redesigning, and people next to me doing fantastic work, but underneath that, you know, we've still got doctors and nurses, you know, as ton of divisions. Well, if you really think forward, even some of those things will need to be rethought over the next 30 or 40 years. You've got an information revolution that's transformed every other industry and has yet to transform healthcare. And when Microsoft and Google and Cisco, working with us, find the entry points into health, because they're hovering around healthcare globally, trying to figure out why they can't quite get the same explosion. But when they do, people like us in our 60s and 70s and 80s will be managing our own care, we'll be interfacing with humans when that's the right thing to do, but, you know, highly intelligent databases. We'll be managing our own results. Our expectation will be of care being built around us as individuals, not as us having to kind of go to other institutions. And this isn't science fiction. I mean, the reality is pretty much all of the technology to do that exists today, but the power structure in health isn't allowing it in, but it's coming. It's coming. So I think the next 10 to 15 years are about redesign of systems within the current model. But while we're doing that, we need to begin to understand how, you know, when I'm 75 with my heart condition, I insist that I am going to be managing my own care and drawing on people when I choose to do it for my own needs, not the other way around. And you're the same. And it's coming. It's coming.
Absolutely.
And you know, one of the main things I talk about is thinking differently. And I think what Jim says is exactly right. I think we've got two links here, and one goes with the patients again. Because one of the major principles about thinking differently is let's think outside of our industry. Let's learn to see what other industries are doing that we might adapt to fit our own industry and grow that. And patients and their family members are all experts in other industries, whether that's a mother with children who's an expert in management, whether that's somebody who works on the aerospace, whether that's somebody in engineering. And we've very well adapted lean techniques into the healthcare industry, and that's a very good example. We need to do more than that, and particularly linking in with information technology, but in the same time build patients and family members' confidence that they can use that technology. I think people who are in their 20s now are way ahead of us. They already do not want to turn up face-to-face appointment. They want to text message, they want to Twitter, they want to have email consultations. The revolution is coming, and the people who can manage that well are coming as well. We need to look after our generation to make sure that we can feel confident in using those new ways.
But it will be the Facebook generation who will have long-term conditions very shortly,
Yes.
and you're absolutely spot on with that. And don't let anybody tell you that those who are, that's fine for the middle class, well-educated, so on and so forth. Not long ago, I went to a town in the north of England to an estate there, a housing which they used to call Lebanon, because you didn't walk around in two, you had to walk around in twos. And I went to somebody's house, a person who'd always worked manually, not highly educated, showing me how they were using their supermarket top-up mobile to enter their data about their blood pressure and the graphs that they had been able to demonstrate. And I said, well, what happens when you take those graphs to your doctor? Oh, they just ignore them. And we have to get over that cultural barrier, but also that it is everybody who can do it.
So we're almost closing the circle here, because then I think we're back to the national level to point out the direction.
Vision.
The vision, the strong vision that really collects all people in one direction. Last word from each of you. How can we create that strong vision?
It's a big personal challenge for me at the moment, and it links to the fact for us, and I think for you too, that our systems are very tightly connected with politics, national politics. So the vision that we're describing is one of fundamental change in the things you recognise as a national health service. So at the moment, the visible symbols for people are their hospitals, and I want to be part of creating a vision that says that those shouldn't be the physical symbols. It should be our mobile phones, and that's what it means. And the political courage to do that's quite difficult. These are difficult issues. So one of our big questions is, can we set out a vision? Now, interestingly, in the 1960s, on mental health, that's exactly what our country did, which is a politician, actually someone whose career was blighted by being associated with issues of race and all kind of problems, so a problematic politician, but was the health minister at the time, and stood up and made a speech called the Water Towers speech, where he talked about the big water tower that you'd see in every city associated with a mental health asylum with 500 beds or 1,000 beds or 2,000 beds to care for mental health, and looked forward 30 years and said, it's not going to be like that. That's not how we are going to care for people with mental health. And that started the long and difficult journey for us to create care for people with mental health problems to live their lives. And now in towns we have 15 or 20 mental health beds for people with really acute needs. And I think the vision we need is to create that journey for physical health, for the people with long-term conditions, so that our hospitals that we're so proud of, and they're wonderful places for the acutely ill, are symbols of failure. And we need to have a national vision that says that our aspiration should be to have small hospitals, because the people with heart failure and the people with chronic lung conditions don't need to use them. They're living their lives. But it's a brave vision.
But it's also important to understand that the generator of that speech was actually an issue which came to light, which led to lobbying and conversations to get the politician to a position where they'd make that speech. And that's the bit we haven't yet done for long-term conditions, other things. But Jim's quite right. We need to be now where mental health was 20 years ago.
I'd say create that vision, make a story. So what will Bob, with his diabetes, how will he live with his diabetes in 5 years, and how will he live with his diabetes in 15 years? Create those stories, because then people can relate to those.
Så det altså utfordringen som vi står overfor i den norske helsetjenesten. Hvordan kan vi klare å skape en helsetjeneste i fremtiden hvor både Ola og Kari faktisk er i stand til å leve det gode livet, utvikle god helse, og dette til tross for at vi dobler antallet eldre. Vi får ikke de samme oljepengene, men vi skal ha den beste helsetjenesten. Fordi vi er villige til å gjøre de forandringene som må til, og vi vil gjerne starte nå. Og derfor har vi denne workshopen, derfor ønsker vi dere med på laget, og vi vil takke panelet for et fantastisk bidrag til den diskusjonen vi har her hos oss. Thank you a lot for joining us and for bringing us into the challenges in the way you did. It was wonderful. Thank you so much.
Thank you.